Oh, wait a second. What? Why is Mark speaking? Where's Jana? What happened to Jana? So Jana is off on maternity leave. She has not yet had her second child, but we were in touch with her on Monday, and she's eagerly awaiting that happening. So that'll be happening very soon. But she's left us in very good hands with Molly, who you know. But the other person we want to introduce here, and something very important that Jana did over the last few months prior to her leave, is she said, Mark, we really need to expand the provider relations team. There's a lot going on, a lot of things to do. And we really love to hire another really solid person for the team. And I said, okay, to that. And Jana went out and she hired, and I am very pleased to introduce Selena Sackman. So Selena just joined us about 6 weeks ago. And I'll let her tell you a little bit about her background, but she's hit the ground running. We are thrilled to have her on our team. Think she's going to be a real asset to us and to all of you of our participating providers and office members of the office leadership team of our practices. So I am glad to introduce Selena. So Selena, take it away.
Wonderful. Thank you so much, Mark. I appreciate the introduction.
Sure.
Hello, everyone. So happy to see so many faces on this call today. I am coming to AHP from Elizabeth Wendy Breast Care, where I was the community liaison for quite a few years. My main focus was cultivating, maintaining relationships with community organizations and referring providers. So I'm very happy to be here. And I know Mark said, welcome back to Molly. And we have a saying here at AHP that if you come back, you need to pay your baby tax. So this is baby Lucy. We are so thrilled to watch her grow and happy to have Molly back. She is junior provider relations. She keeps her mom up at all hours of the night with fresh ideas and wonderful things to bring back to our team. So, welcome back, Molly. So happy to be working with you and baby Lucy.
Thank you,
And with
Selena.
and with Jana being out, since we're a little short-handed, it's possible baby Lucy may be visiting your practice. We ask you to welcome her, and she's a little behind in the details of some of the things, but just be patient, and
Say
we're,
more.
we're sure she'll do a great job.
It's about time she brings in a paycheck, so we're happy to have her on the team.
So with that, we do have a couple of departing staff members that we'd like to just wish well on their new journey and much success in their new roles. So we recently said goodbye to Jenny Radcliffe and Jalen Kim. So, moving on to our agenda for today's meeting, Mark already covered our staff updates along with me. We have Dr. Chad Teeters, who's going to discuss the current state of AHP as our interim CEO. Then we are going to have a Health Catalyst update from Christy Howd, our Director of Information Management and our Security Officer. We are going to discuss our 2025 PCP reward plan. We have Kevin Kelly, our Project Manager for Business Operations, talking about our quality program, and I will be discussing the citizenship for 2025. We do have Bob Adams, our Director of Pharmacy Services, that will be going over and talking about a new community initiative. We will talk to our care management program. Danielle Calder, she's our Associate Director of Adult Care Management and Clinical Protocols, to discuss the redesign of our adult care management program. And then we have Dr. LJ Shipley, our Associate Medical Director of Maternal Child Health, to discuss the New York HER 1115 waiver. And then we hopefully will have some time for open discussion. We do have a packed agenda for today. So if you have questions or things that you think of throughout the presentations, please feel free to put those in the chat. Molly will be monitoring that for us. So moving right into our current state of AHP, Dr. Teeters, would you like to take it away?
Absolutely, although that Dr. Teeters thing makes me very nervous. Hi everybody, I'm Chad Teeters. I was going to put in the chat like I'm like janitorial closet services or something like that, but I am currently functioning as the interim CEO. Most of you probably remember me or got aggravated by me during pandemic when I was still in the executive medical director role. I kind of stepped back when I'd moved to Noise CEO into associate medical director role for about a year or so. And then with Bob McCann's planned retirement, the request from the AHP board was to have some transition period so that they could perform a national search, which they anticipated taking 3 to 6 months. And so I have stepped into that interim position while still keeping the Noise CEO hat as well, while that search is ongoing. So for kind of current state of the union, lots of activity going on. Obviously, by the very fact that you're listening to me right now, we are obviously in the midst of the leadership search. That process started back at the end of the year in 24. And the process is going on. It anticipated that the search committee will likely come to a resolution and make a final offer on the chosen candidate probably in the April-May timeline. I know that the candidate pool has been whittled down to kind of the second group, if you will. So I guess I'll call it the semifinal round. And then from this group, they'll be chosen probably 2 to 4 candidates who will be brought on site to meet with multiple stakeholders in that final round. And then based on those interviews, the final offer will be made. So good news is there's been really great candidates from really all across the country. So pretty deep pool. I think there were about 10 to 12 candidates. I think the slate has been whittled down to 6. And like I said, over the next couple of months, the team will be completing their work to find the new permanent leader for the organization. So more to come on that. In the meantime, I think one of the important things that we all realized from the HP leadership team was that we really couldn't just sit around and rest on our laurels, and that there was a lot of things that were going to be transpiring in that 6-month window when we were in the midst of our own leadership transition. So it was very important. The leadership team got together, maybe with some light coercion from me, and we came up with kind of what I'll call 6-month strategic plan to at least move the organization forward and leave it in a better position, and at best to get us kind of a running start to what hopefully will be the new plan to carry us forward in the years ahead. I think most of us would probably understand and agree that over the last couple of years, we've seen a little bit of a diminishing gain share, and a lot of that is largely due to the conservative tendencies of our MCO payer partners. And the value-based contracting opportunities have started to become a little bit thinner unless you're willing to put more dollars at risk. Now, AHP, obviously we have AHP Insurance Company, and that prevents us from ever having to come back to any of you and ask to cover any deficit that we incurred in one of our contracts. But it is not an ever-fulfilling fountain, and we are not an insurance company. So we can't reset the premium next year to restuff those coffers. So we do have somewhat of a limited depth of that indemnity fund that we can call on. So it limits our ability to have high upside when the insurers have largely asked for somewhat of a balanced downside risk. So we are actively right now, one of the it's largely either the insurers want to see that you're willing to indemnify the risk, or you're willing to provide the infrastructure for delivery. Obviously, AHP has a robust care management team. I think we have a growing pharmacy team. But if you look nationally, and if you look at some of these third-party vendors that are starting to enter into our market, they're bringing things like geriatric home visits, expanded comprehensive medication management, certainly around hierarchical complexity coding, other tangible things that tend to drive revenue and reduce costs. So one of the big facets of this 6-month strategic plan that we've put together is to position ourselves to be the purveyor of those services so that we do not have to contract outside, because every time we go to contract outside, that means we're splitting the pot with someone else, which just means we have less to share with all of you. But it also, the more robust the breadth of service that we are able to offer, the more attractive our services become to other payers and even other self-insured employer partners. And we're starting to see some of that now. I will tell you that the last couple of months in particular have been a flurry of activity with engaging with new potential contracts, certainly expanding our care management resources, trying to focus more attention in the chronic disease management domain where we have a lot of spend and utilization. But then also in the analytics arm, we've talked extensively, and we'll be hearing more about the Health Catalyst implementation, which we know is going to propel us forward mightily in both our ability to present data to all of you, but also to support some of the analytics approaches. But we've also put a lot of effort here in the last couple of months into supplementing some of our resources with generative AI technology, with the ultimate goal to reduce the manpower effort and increase the amount of data that we can provide at point of care in kind of a just-in-time or as-needed way. So rather than pilfering the chart to find out how gaps were closed 5 years ago, or to see what studies have been done since the last patient came to your practice, one of those technologies that we're working on is what's been named PreChart Pro, which is a report. It's like a one-pager summary that will come to the inbox of your providers or your office the day before or the day of the visit, that will kind of culminate all of the things that happened since the patient last crossed your threshold, and active issues such as health gap closures, high complexity codes that need to be considered, so on and so forth, to better inform the point of care and make it easier to deliver that care without humans having to do a lot of that data mining and slowing down the care delivery process. So more to come on this. We've been talking about this in our provider advisory groups. As we get more tangible resources into production, we can bring those forward to kind of present and show a little bit more about exactly how we plan to incorporate that. But our goal is by May of this year, which I know seems like a very aggressive timeline, to be in a much more strengthened position to be able to have some of those service offerings in production and in delivery, but at least to have a strategic development plan for this team to be ready to take on more risk, ready to hopefully negotiate for new contracts and expand our opportunities to earn gain share, to be able to distribute to all of you, and also to support that team-based healthcare to carry us into the next phase of what I think is going to be healthcare delivery, which is going to be much more emphasis on value than fee for service and volume as we have in the past. So lots more to come in that vein. Don't want to hold us up because I know we have a lot to cover. Certainly, we will continue to share with you guys the evolution of the CEO search and development there. But like I said, probably a couple more months before we get to conclusion of that. And in the meantime, we will all be diligently working behind the scenes to hopefully get us a little bit farther down the road for whenever that permanent leadership change occurs. So thank you for all of you, and happy. If anyone has questions or things that they're interested in, don't hesitate to reach out to me or anybody else on the team, and we'll continue to touch base and update you more. So thanks so much.
Thank you for that update, Chad. So next we are going to Christy Howe to discuss our Health Catalyst update.
Good afternoon. So it's been a while since we've talked about Health Catalyst, and just give you some highlights of all of the hard work that's been going on for the last year and a half. As you know, we started a 24-month or 2-year implementation of Health Catalyst in October of 2023. And we are down to our final 7 months out of those 24 months of implementation. As you can imagine, there's been a lot of work going on. And we have, in case you don't know, 56 different data connections that we've had to make across the network at AHP. And most of you have already been working with Willie on making sure that we're getting those connections into Health Catalyst. Happy to say that 18 of those are complete, fully passing data through our quality measure engine and being visible to us in our dashboards and reporting. 30 of those connections are in testing right now. Testing is doing great. And if you remember your role in the Arcadia implementations, you were very heavily involved in testing and validation during the connection implementation. And so the fact is, we're quite quiet right now because we can do most of it ourselves. And so as we start to get to the point of being able to serve up some dashboards to y'all, we will be looking at you to do some final, sniff testing on things. But I'm really pleased to share that we're implementing so many more checks and balances and stops along the way to make sure that the data that we're receiving from you is looking good and ending up in the right places. So that leaves us with 8 that are in an intake process. So if you haven't been working with us yet, or
very
in the
nice.
early stages, please be really timely with your responsiveness to Willie and work with your vendors to make sure that we get this implementation done in the next 7 months. The sooner the better. Yeah, because we just need the time. It takes time to load the data, to look at the data, and to make sure it hits correctly. In addition to getting data flowing, our analytics team has been developing dashboards. So we're placing a lot of the Arcadia functionality with quality measure dashboards that you're going to see through the provider engagement report. Those aren't being rolled out as yet. We're not quite ready there, but there's a lot of tools that we're using internally within HP and doing validation and utilizing that functionality. So a lot of what we're going to be presenting and sharing with you in the coming months are what you're going to be seeing around your patients and your practices, replacing a lot of the functionality that you were used to using in Arcadia. And hopefully you'll be as pleased with the transition as we are. Any questions?
All right, not hearing any questions. Thank you, Christy.
And Celine, I'm just going to pop in real quick just to give one other reminder, anybody on to put their name and practice name in the chat so we can make sure you get your credit for being on today during lunch.
Perfect. Thank you, Molly. So now we are going to move into discussing the 2025 PCP reward plan components. As most of you who have been with us for a while understand, there are 3 components to this reward plan: the quality program, pharmacy piece, and citizenship. So right now we are going to start with our quality program, and Kevin Kelly is going to discuss the 2025 program.
You, Selena? Yes. Hi, I'm Kevin Kelly, project manager at HP. If I don't know you, this is my 5th year at HP, so if we haven't met, just want to introduce myself real quick. This is very high level, as Christy just went over the kind of the Health Catalyst implementation and kind of performance tools we'll be using. But just really wanted to keep it high level and give you guys the opportunity to ask any questions or concerns about the 2025 quality grid, but it should look familiar. And I will be putting in my email just in case you wanted to kind of set up a one-on-one time for more specific practice questions or any questions you have about the 2025 quality measure grid. So I will be going over the table of the quality measures in the next slide, but these are the only really major change I wanted to bring up is I'll be, taking the lead on the quality measure communication moving forward, taking over for Elizabeth. And the other change is diabetic KED. This should be familiar with you, but last year it was report only. So providers will be held accountable for diabetic KED this year. But as you all can read, adult measures are pretty much the same other than that. And then the pediatric measures have remained the same. So that is all I had, unless there are any questions or concerns that anyone wants to bring up.
All right, thank you, Kevin. So next I am going to discuss the citizenship components. As usual, there are two ways that citizenship components can be satisfied. There is the practice level components and then the provider level components. So here is just a breakdown at the practice level. So for practice manager, attend 2 or more of these meetings and participate in any of our optimization, administrative projects, or other pilots that we have happening. Bob is going to describe one of those in our next slides here. And then again, participate in the Health Catalyst work that we have, be responsive in validating data and timely responses. All of those things will earn your whole practice the citizenship component. The next level is on an individual provider level. This can be satisfied when 2 or more of the following are completed, and you can see all of the ways here. So come to our information sessions, subscribe to our email communications, are you accepting new patients, serve on any of the boards that we have, and then Vatica participation. So we do have some upcoming incentive payments that are scheduled. So fourth quarter 2024 clinical integration payments are scheduled to be sent out April 2025. Once those are sent out, your provider relations rep is going to reach out to you just to confirm that those have been sent. And the 2024 PCP reward plan payments will be sent in August or September of 2025. So right now we are going to move over to Bob Adams, who's going to discuss one of those initiatives that we were discussing earlier. Bob, are you ready?
I am. Thanks, Selena.
Yep, sure.
Yeah, so my goal actually today is really kind of leave you wanting more. So this is more of a teaser. So we have this project, it's a 3-year project that we've been working on, really led by LJ Shipley, to redefine and kind of help in the asthma space. So if you want to go ahead and flip to the next slide. So it has 4 kind of main goals. We want to implement a comprehensive phased approach for appropriate diagnosis and management to improve asthma control from the earliest ages. And really this is guideline directed therapy. It's kind of moving that needle in the direction to help our asthmatic patients. And we want to reduce preventable ED utilizations and hospital admissions. We want to improve the quality of life in school and attendance for our pediatric patients, and ultimately reduce adult morbidity from reduced lung function and COPD related uncontrolled persistent asthma. Those are the main goals that we have for this project. So go ahead and go to the next slide. And so how is this set up? So we've got this large kind of collaborative, it's a community-wide project. It involves URMC providers, Rochester regional providers. I'm on the pharmacy subcommittee, and it's co-led by Corey Wyman, who's GRIPA, who's my counterpart over at GRIPA. And we've got people from Trillium, from Wegmans, Excellus, MVP, lots of different payer groups as well that are part of that pharmacy subgroup. But not only is the pharmacy subgroup made up of a diverse group, we've got an ambulatory group that's got people from Jordan Health, URMC, Rochester Regional, again, the emergency departments. It's really, the goal is to try to find a way to kind of, as a community, come together around asthma and really help our patients achieve better outcomes and change the narrative. And that's what we're going to talk a little more about. And overall, that we kind of have an umbrella, a steering committee that kind of leads and guides all the different committees that they, for example, one of the things that for the pharmacy group we've been working on is some educational materials of Pearl. And so we've got this content we're developing as pharmacists. We share that with the ambulatory group to get the feedback from the providers who shares it with the inpatient and specialty groups, make sure that the allergists and folks are all online, pulmonology is online with what we're promoting in the future. All right, we'll go on to the next slide. And so again, this is really guideline-directed therapy. And what it focuses on is the GINA guidelines. So in 2020 is really when asthma, the approach to asthma started shifting. But we also know that in 2020, that was the heart of COVID, and this has easily gone by the wayside because there was a lot of things happening during 2020. So one of our goals is really to kind of get out the information around the new guidelines that Gina's promoting, really changing the narrative of asthma that patients are okay to live with symptoms, to live with barriers, to live with quality of life issues related to their asthma. And we want to make sure that people don't think that that's okay. It's pretty common for people to think, my asthma's controlled. I use my inhaler when I have symptoms, and if it gets real bad, I take some prednisone and I go to the ED. No, that's if you're taking oral steroids or if you're taking systemic steroids, that's kind of a sign that that's a treatment plan failure. We need to do better by you. And how can we do better by you? All right. And so we'll go to the next slide. And so the pharmacy work group, we have been doing a lot of work. And again, this has been a partnership between myself and Corey Wyman from GRIPA, who's under Rochester Regional. And we're working on creating smart order sets within the EHR system. So we've partnered so that, Epic is a large swath of the community, but we also know that there's MedEnt users and other EHR systems. So our goal is, starting with Epic, kind of building out what these smart order sets would look like. And then the goal would be to bring them to other and cascade them out to the other EHR systems so that whether you're a patient going to seek care at URMC or a community HP practice or Rochester Regional practice, it's the same kind of orders that are going to be written. And, by having these collaboratives with, the payers and Excelis and MVP and the pharmacies like Wegmans, it allows them to ensure that, what we're trying to create, these orders that when they're written, they go out, that, the pharmacy receiving them is going to fill them. They're not going to be questioning them. It's very common. And, when we were originally taught that, you've got your controller medication and you got your rescue medication. But really SMART is a single maintenance and reliever therapy. And the goal is that you have one device that really is how you start your asthma journey and you use that device. Well, if that prescription goes out, it would be pretty common for a pharmacy to call and say, hey, I've got your maintenance inhaler here, but where's the rescue inhaler, right? So we know that we can't just target the providers, we got to target the community and do that through education. All right. And so, it's we're in kind of like the second year of this whole project, and what we've got and what we've started on is the SABA stewardship statement. And what that means is that really Gina is the guidelines are saying that, short-acting beta agonists, the albuterol inhaler for asthma as the primary backbone of treatment is wrong. It's unsafe. We can do better. And so it's really to set the focus that we shouldn't be treating asthma with just an albuterol. Yes, that will help with the symptoms, but it doesn't address the underlying problems that are happening with the patient. So we've created the SABA stewardship statement that we're starting to circulate, and we want to get out into the community. And we're now at the point where we're starting to engage our primary care practices. That's where you guys come in. And also we've got some meetings coming up with our urgent care practices as well. And so we're trying to come up with common language within both our EHR system, within our education, within the way that we're handling our patients so that care is common throughout the community. All right. So, the goals of asthma treatment, and this is straight from Gina, and it's really, this is where they started to change things, that symptom control, that there's be few or no asthma symptoms. You shouldn't have sleep disturbance. You shouldn't have exercise limitations. I want to reduce that risk, improve stable lung function. We don't want to have any exacerbations that require steroid use. We're trying to minimize the medication side effects. And, no requirement for systemic steroids. That's a big one. We know that especially with our pediatric population, that can be very impactful for them. And we also know that patients' goals may be different. So we need to talk with our patients and try to educate them so they realize that, I've had asthma for 20 years. I've been using my albuterol all the time. So now I want me to do something different. That's going to be a change for them. People will become very comfortable with their medication in that space. And now we're trying to challenge them that no, there's a better therapy for that. All right, next one. So our SABA stewardship statement, it's really meant to address the overuse that's leading to harm. Recognizing that, overuse of albuterol is a leading way to end up in the ED. It's not addressing that underlying component where there's typically inflammation that's causing the symptoms of asthma. So, the idea is here is that, from an early age, from 6 on, that we really want to move patients into this single combination inhaler consisting of an anti-inflammatory inhaled corticosteroid and a reliever medication. And that should be, first line for both therapy, for rescue and prevention. That's the goal of the new asthma initiative in SABA. All right. And so it's all predicated around these medications. So Symbicort was the brand, and you've got now generic Breyna on the market. You've also got Dulera, which also has the same thing. So you have this combination of an inhaled steroid with a formoterol long-acting beta agonist component. And it's that formoterol that allows the patients to feel the relief just like they did with albuterol. But you've got that inhaled steroid that breaks down the inflammation and causes, prevents that cascade of events that causes the reaction to continue to get worse and worse and worse for the patient. And so go to the next slide. If you're interested in hearing more, so I have a partner in this saga, Paul Tremblay. He's a nurse. He's done a lot of work with Jill Halterman in the space with pediatrics and asthma care throughout the Rochester community. Paul and I, for the last 2 years, we visited 11 different practices and really started to talk about smart therapy, talk about asthma, talk about the changing assessments that are around asthma and how that we can simplify the process to identify those patients that are at risk easier and faster. And if that's something that you're interested in, please let me know. And Paul and I'd be happy to come out and do an in-service. And you also get that citizenship check mark too if we come and visit and talk with you. And overall, I feel like this has been a very positive thing for both Paul and I, but also for the providers and practices that we've been able to visit. I feel like we have learned something every time we've gone out there. But again, it's a great way to help our community and get us all on the same page.
Wonderful. Thank you, Bob. Are there any questions?
Selena, can I just put in a plug for this for a second? I wanted to thank Bob for the work that he's done in going out to our practices and just highlight a couple of things here. What's really unique about this model is the extensive collaboration across all of the levels of systems. As Bob talked about, we're in the first part of this initiative, we're trying to move towards uniform adoption of evidence-based care, following the guidelines. That includes smart therapy, but it's more than that. It's also really looking to make sure that our teams are able to recognize and diagnose asthma at the earliest possible age. And so the work that we're doing with Peds Pulmonary and allergy and the hospital teams and the emergency department and the urgent cares and with all of you will make it for a family from a child with asthma to be so much more seamless when they come to your practice and receive recommendations from your providers. And then if they do land in the emergency department or with a specialist or in the hospital, if they're getting the same recommendations. That would not have been the case a year ago. So it's taken quite a while to get sort of all the players together. And we're super excited that this is a partnership with our colleagues at Rochester Regional and GRIPA. And that's how we really win for kids in this region, when we actually work together across these kinds of initiatives. So we will be reaching to you also to schedule one of these practice visits for your providers, because we've got now the guidance, the language, the tools, and the buy-in from all the other system teams, so that you will be getting the most up-to-date information. Your providers will, your whole teams. It's important for your nursing teams to hear this information too. It is a shift, but it's a really important shift, and it's one that I think our community can start to lead on, even nationally, as we do this work. And we're really excited as the reimbursement structures begin to change, we hope, for these type of combined inhalers in the adult population. The relevance to adult asthma is there as well. The barriers are a little bigger right now, just in terms of being able to get the appropriate inhalers filled. But these guys, Bob's team of pharmacists, have worked through all of the barriers that did exist over a year ago to actually getting prescriptions filled. And so we're really excited to work with your practices. And thank you to those of you who informed this work all the way along.
Thank you very much. So I am going to stop sharing my screen. We have Danielle Calder, who is going to discuss the adult care management redesign. So Danielle, feel free to take it away.
Thanks, Selena. So sorry about that. I'm Danielle Calder. For those of you that don't know me, I'm the Associate Director for Adult Care Management and Clinical Protocols. We've been doing a lot of work on how do we move care management into the next phase. As you know, our current state of care management is kind of a bunch of different models. We have our embedded model for some practices, centralized, and then hybrid. Primarily, our support to your practices focuses on transitions of care. This is with our 5 contact program, looking at patients being discharged from the hospital and then providing those follow-up calls and following them for the next 30 days after that discharge date, as well as our complex care management program. Right now, our referral stream for this work is really driven by the clinicians in your practice. The model to your right is what we use to really think about our work as we move into this next phase of care management. One of the things that we have identified is that partially because we rely on providers and clinicians to give us referrals, it does cause some variation in how we deliver our care management interventions. And we're hoping to get more standardized and purposeful around how we're identifying our patients, creating workflows and protocols for specific disease conditions, for example, and then measuring the impact that those have on our workflows, as well as using those measurements to increase our quality of improvement. I kind of walked you through the model on the side. If we actually actualize this model, which we've had a lot of barriers in the past, but our hope is that we can do that successfully this year. We are looking to transition our care management program to a more structured population health focused approach, using Health Catalyst to help us identify patients who would be eligible for these disease-specific programs that we're creating. In the last few months, we have finalized 6 standard pathways for care management in heart failure, diabetes, hypertension, COPD, depression, and then just a general complex care management pathway. Each of those protocols or pathways have inclusion and exclusion criteria that we would start to use to identify not just the patients we work with, but how long we're working with them and what we're doing while they're enrolled. There is a minimum required set of interventions that we're expecting. Of course, care managers can individualize their treatment plans. Treatment is a loose word, but care plans to meet the needs of their patients, but we are expecting that every patient, for example, with diabetes has lifestyle modifications and self-management skill building built in. Our pathways do support team-based approaches to care and can be done in both our embedded models as well as our centralized care management designs. And we are working on building these into Epic, which, if you are not aware, all of our care managers moved over to Epic successfully last year and have been using Epic, Epic's Compass Rose module to really manage our registry maintenance at this point. So what does this mean for you? The support that we offer for care management won't change. You'll still have your nursing, social work, or data coordination support. With the shift to a more population health approach to how we're identifying patients to care management, it may mean that not all patients that were previously included for care management support will continue to be. We don't know what that really looks like yet, so we're going to have to get creative together and kind of live into this new phase a little bit. And your feedback, your experience is all going to be really important and valuable as we go through this process. Any questions?
All right, not hearing any questions. Thank you so much, Danielle. So next we are going to have Dr. LJ Shipley discuss our 1115 waiver.
Hi, everybody. I do not have any slides to share. With this, I'm just going to talk through what we know about the waiver at this point, and most specifically, what we understand about participation with the social care network. So the current Medicaid redesign waiver, which is the New York Health Equity Reform, or you'll see it written as NYHER, waiver, is really a demonstration project, which is what all of these waivers are. And the focus is included in the title. This is really about equity. And so in this particular, this is different than past waivers, the DSRIP waiver, other things that came to our systems. It's really very focused on elevating and leveraging some Medicaid payment for some of the specific things that really make you think about what is health beyond medicine? What is health beyond medical care? And so really focusing in on the social drivers of health and social care needs that impact our population. And so the way this is being approached, although there's sort of there's a multi-tiered approach within the waiver, some of it is around workforce development, some of it is around ultimately moving towards more of a alternative or value-based payment model for New York State and working with their Medicaid population, both for adult and for pediatrics. The piece that's right in front of us right now is really all around the social care needs. And so the mechanism by which the state has chosen to implement this work is to name certain regional leaders in this space who are the social care networks for various regions. And as I'm probably telling most of you things you already know, but I just figured it's good to kind of level set at the beginning. For our region, FLIPA, which was in the old days was Finger Lakes IPA, but with the same acronym, they are Forward Leading IPA. FLIPA was the group that was contracted with from New York State to be sort of the leader in our region around for this social care network. And so a lot of you have had questions right now about how do we participate with the social care network? And I think that for many of you, that question is coming from two different reasons. One is because you want to do well by your patients. You know that this is important work. We want to be really responding to these social care needs. But a particularly driving factor right now is the fact that New York State has also laid out a plan for increasing reimbursement through PCMH in order to begin to pay more for patients under Medicaid. We know that Medicaid has traditionally been underfunded in terms of what comes to primary care for support. The PCMH model for enhanced PMPM has been one mechanism by which they have increased payment. And this now, the plan for this year is to add an additional $4 PMPM to the current $6 PMPM for practices that participate in PCMH. And I know, I don't even need to look at your faces to know this, that is really important for so many of you who care for many patients who are on Medicaid. But the state has required that practices who are participating in PCMH and want to qualify for this enhanced rate are attest to the fact that they are participating in the waiver work. And so many of you have been reaching out with, what does that mean? Does working with AHP mean that I qualify for this? Do I need to sign on into a separate contract with FLIPA for this work? And so I just want to update you to where we are right now, tell you what we understand about the actual work of this. And I'm going to leave you, this is probably not the teaser you want, but we don't have a conclusion yet in terms of knowing exactly how this is going to pan out, because much of this work has relied on waiting for approval from the state, contracts from the state. And so we've just been given that information. So I want to be as transparent as we can, but at the same time, not, overpromise something, because we still need to figure out some of the details. So the work of the SCN, essentially, if you break it down, is to assure that every patient, adult or pediatric, who is on Medicaid, fee-for-service or managed care, receives one social care needs screen per year. And the social needs screen really is, all the terms keep changing. People don't like social determinants of health, but a lot of us still recognize, SDOH. It's basically a social determinants of health screen. It is the one that has been elevated by CMS. It is the accountable, oh my gosh, now I'm going to mess this up. Accountable Health Communities screener. You can find it online. It's about a 14 or 15, question screener that covers broadly social drivers of health, like any other SDOH screen. It is not specific to peds for those of you who are pediatric specific providers, but it covers more broadly the screening questions. So that screen, when completed, needs to be entered into the platform, the data platform that FLIPA is working with, because part of this is for the state to collect data across the whole state of what are the social care needs of our population. Then the next step in this work is navigation, and it's basically determining qualification for services. So patients have to have some kind of a qualifying diagnosis or condition that would then allow them to receive some services under this waiver. So it's a chronic medical condition, or if it's a child who was premature, or someone who has got a mental health concern. Their definition of chronic conditions is wide, but you have to match that up. And then there are specific social care needs that are being met by this waiver, and they fall into the bucketed categories of transportation, food insecurity, and housing. And within this platform, they're able to help make some connections for those services and make recommendations for community-based organizations or agencies who can deliver services in those categories for patients who qualify. The other part about this waiver is not just about the screening and the care management stuff that we know about, but it's actually to get Medicaid payment for delivery of those types of services. So it'll be the first time that Medicaid will really pay, for example, FoodLink. Beyond what you would typically get with SNAP benefits, you would actually get payment for services. Or if someone needs housing modifications or support to achieve housing, actually have Medicaid payment to support that. I could go on with examples. So that is the way this is structured. And the goal for this is this short-term waiver. It took a long time for it to go through. It's 2 years of work, and it's starting now. And the conclusion of this, the information that they glean from this over a 2-year period will help to inform what is needed in our state and what could be supported better from Medicaid for patients on Medicaid that meets their needs. So we want to be part of this. We think it's obviously really important. I think all of you recognize that social care needs impact everything. They impact a patient's mental health. They impact their ability to actually follow through and work with you around recommended medical interventions, right? So we want to be in that space. We also do not want to get in the way of practices or systems who've already figured out the way that they want to do this. And so it is possible to contract directly with FLIPA, and some practices or some systems have done that already. But we also want to be mindful of the fact that we do a lot of this work with our care management teams. You just heard about Danielle's conversation. I'm looking right at Robin McElligott right now and our care management team. You know that we're in that space working with you around the identifying patients with needs and helping them get to required services. So what we are doing right now from the AHP end is looking at a new contract that was just developed last week for the potential participation of an IPA organization like AHP with FLIPA, working with our practice partners, leveraging potentially our care management services in this work. And so we are going through the details right now. What does that look like? What would that mean? And if we're able to negotiate something that comes through participation with AHP and attestation that you want to do this work, with us may be a possibility and would satisfy requirements for the whole PCMH additional $4 per member per month. The most important thing is doing the work, and we would be working closely with FLIPA. What I can't say to you right now is that contract is not signed yet. I mean, we literally, I received the contract and put it in front of our team in the last 24 hours. And so there are a whole series of meetings that are happening right now between us and FLIPA, because we do not want to, again, don't want to get in the way of your practices doing work that you may already have figured out how you want to do, but we want to be able to support this going forward well. It is in complete alignment with our mission to promote equity for our patients and our families. And what we anticipate is at the conclusion of some more meetings next week by midweek, we would like to be able to get back to you with a definitive, description of what should happen. And what we are anticipating doing is holding a forum with FLIPA for these practices. So you can anticipate an invite to one of our old COVID calls, but doing a meeting where we can discuss questions and make things very clear. Honestly, we will do that. I would like to just promise we will do that regardless of whether our contract can go through with them, because we want to make sure you know exactly what you need to do or what you can do through our team. So I hope that wasn't as definitive as we would all like to have had it be, but we are moving as fast as we can as the information is coming our way, and just want to make sure we really can do good work. And I'll turn it to Chad or Mark first if they want to add any other comments to what I said or any clarifications.
No, I think you were pretty thorough, so I don't have anything.
All right, so with only a few minutes left in this meeting, we want to make sure that everyone is able to have a timely exit. This is just a reminder of the practice manager meeting scheduled for the rest of the year. Our next one will be June 11th. It will be 50 degrees warmer and sunny. I could just predict that now. Again, all of our meetings are changed from 12 to 1, so you can enjoy your lunch with us. And just a few reminders as we close out this meeting that yes, we are an AHP participating provider. We do have window clings available for you to note this in your practice. If you need any of those or would like any of those, Molly or I are happy to deliver. We also do have a new vector file that's been created if you'd like to post this on your website. So being part of AHP means that we refer patients to AHP specialists, admit patients to AHP hospitals, and send patients to AHP imaging labs. And for your practice, we just hope that you do monitor your provider engagement report, participate in these meetings, accept, read, and share our AHP communications, especially those pharmacy pearls that are very well received and well shared, and help other providers in the area connect with our AHP resources. Here is a list of the contacts here at AHP. This presentation will be sent to you within the next few days. We will also upload it to our AHP YouTube channel. So that is it for today. We have about 1 minute left. Are there any other quick questions that we have?
Do you send out any agendas that ahead of the meetings? I'm a little bit OCD, so I prefer those.
Yes, I certainly can do that.
Okay. Thank you.
Anything else?
Thanks everybody for spending your lunch hour with us. We appreciate it.
Thank you. Have a good day.
Take care, everybody.
Thank you.
Do you think we used